I'd like to welcome you to Best Practices for Establishing a Grateful Patient Program. Before we begin today's presentation, I'd like to quickly review some logistics for those of you who may be new to Campbell & Company webinars. So to ensure that you have the best webinar experience, please follow these tips. 1, close any programs other than GoToWebinars that are running on your computer. 2, call in using a telephone instead of using your computer speakers. 3, move your cell phone away from your computer. And finally, if you experience any visual issues, send a chat to Campbell & Company, or you can contact GoTo at 1-800-263-6317. Finally, today's webinar will last 60 minutes, and you will earn 1 continuing education credit, and that is good for certification with CFRE International. About an hour after the webinar, you will receive an email from GoToWebinars that includes information on how to register for our next webinar, the PDF of the presentation, as well as information on how to access our YouTube video after the webinar. We do welcome questions during the session, so if you have any, please feel free to send a question to Campbell & Company, and I will ask them throughout. And now I'd like to take a moment to introduce Adam Wilhelm and Holly Jabot. Adam Wilhelm is a Vice President at Campbell & Company. During his tenure at Campbell & Company, Adam has held a number of interim leadership roles, including Chief Development Officer, Vice President, and Campaign Director in advancement departments at hospitals, colleges, and independent schools. Adam holds his bachelor's degree from St. Olaf College. Holly Jabot is a Vice President of Northwestern Memorial Foundation, providing leadership in the areas of major gift fundraising and planned giving for Northwestern Memorial and Northwestern Lake Forest hospitals. Her current primary fundraising efforts are in support of the Bloom Cardiovascular Institute, the Northwestern Brain Tumor Institute, and Planned Gifts. Holly is a graduate of Vanderbilt University. Now I'd like to take a moment to turn over to Adam. Adam?
Great. Thanks, Sarah, and thanks, Holly, for joining me on the panel today. I wanted to get started by, one, thanking everybody for joining us today. We're glad you can join us, and I think we released the full report of the study yesterday to everybody, and so if you were signed up, you should have received that. But if not, I'm sure we have that on our website available for you to pull and download. But wanted to start off by talking a little bit about why we approached researching, getting started with Grateful Patient programs. And some of our objectives for the study. So as we took a look at the healthcare landscape, we know that more and more institutions are having to provide the same or greater level of care to the communities they support for less reimbursement. And so as we move forward with that and some of the uncertainty with the advent of the Affordable Care Act, we're hearing from CEOs across the country that they're looking more and more for philanthropy to do more to help bridge the gap between what was in place in terms of revenue before and what's there today. And as a result of that, there's really an imperative that fundraisers continue to look for opportunities to identify and qualify their patient base and use that patient experience to deepen relationships with donors and begin relationships with prospects as well. So that got us to the question of, in terms of Grateful Patient programs, who is doing well, what activities are they engaged in that are producing robust results. And then from an objective perspective, we know some certain pillars exist already, but looking within those pillars, really aside from sort of the basic structure, what works specifically well and what doesn't. The other part that I would want to highlight just in terms of the motivation is that a lot of the responses to this survey are still very anecdotal. So while we had a number of participants in the survey, we were really just getting into some deeper conversations about what works and what doesn't, as opposed to just working with the data. So some of our objectives, the first, again, was really to identify which practices produce the most robust results. So what has been successful, what has not been successful. Beyond that, what can and cannot be implemented. The written study does not touch very specifically on practical implications, but I'll try and do a little bit of that as we go through the results on the webinar today. But beyond just what's the most robust, where is your time best spent? I think even today, as Grateful Patient fundraising is still evolving, we're trying to figure out where the best ROI is, and because grateful patient activities aren't always directly correlated to fundraising results. We really wanted to dig in and figure out where is your time best spent from that ROI perspective. Secondly, are there differences among different types of healthcare institutions? Children's hospitals, academic medical centers, large systems, and community hospitals. And I'll save you the suspense. We frankly didn't find a lot of difference in the practices, and I'll highlight the few that we did as we move through. And then last, in terms of objectives, was to illustrate an institutional growth matrix, which is consultant speak for wanting to illustrate a way that how programs grow over time. So beginning, maturing, and then strong. We've got that embedded in the study, and we'll highlight that towards the end of the webinar today as well. So I wanted to take a moment and just say thank you to all of the participants in our study. I know that many of you are on the phone today, so I'll say thank you to you directly. As you can see, we had participation from organizations both from an institutional variety, as I mentioned, from children's hospitals to community medical centers. But we also had, I would say, a good representation, small, medium, and large, both in terms of the size of the institution, so beds or number of acute care locations, as well as a variety in terms of fundraising results, which I'll highlight in a minute. I was also happy that we were able to engage institutions both here in the Midwest, we're in Chicago today, but also up and down the East Coast and up and down the West Coast. So we feel like we really got a good representation of what's happening across the country in terms of grateful patient fundraising. In terms of methodology, it looks so simple when I lay it out this way, but let me tell you that getting institutions to complete a survey and phone interview is no easy task. But that was it. We sent a qualitative survey or quantitative survey, excuse me, that people completed online. That gave us a firm grounding in some data, both around demographics and specific practices, and then followed it up with a phone interview. And again, that phone interview for us, given that we were working with only 18 institutions, was really helpful to sort of draw out, but really what some of those key practices have been as these institutions have begun, matured, and moved their programs into engines that have been successful for their fundraising. Again, 4 academic medical centers, 7 large systems, 3 children's hospitals, and 4 community hospitals. And I think that anybody's on the phone today is familiar with the size and scope of those kinds of organizations. So let's delve just a little bit into the demographics some more before we get into some of the results of the survey and study. So again, we had a wide variety of fundraising results. When you look at total dollars raised for all of our participating institutions, it almost breaks, not evenly, but kind of cleanly from an analysis perspective into thirds. So about a third of our group raising somewhere under $10 million annually or up to $10 million annually. About another third of the group somewhere between $10 and $25 million annually, and a third more than $25 million annually. And I broke it down into those groups as I'm talking to you today. That's where we see some of the breaks, both in investments and staffing, as well as programmatic opportunities. So again, we feel like we got a good representation across the board. Size of fundraising staff or foundation staff, again, split rather evenly. One of the things that I want to point out on this chart is the correlation. So if you think about the chart that we just went over and laid on top of this chart, there's a correlation between frontline fundraisers and fundraising results. And I don't think that would come as a surprise to anybody, but as your institution grows, place more of an emphasis on major gift programs, the number of your frontline fundraisers grow, and very often then we see fundraising results grow as well, which again has implications around grateful patient fundraising, because those frontline fundraisers are very often the people that are visiting patients, engaging physicians, and then of course doing the follow-up that leads to major gifts following that identification and qualification process. So this was an interesting slide for me in relation to the last 2 charts that we looked at. So whereas it broke easily sort of into thirds, both in terms of fundraising results and fundraising staff. It was interesting both as we looked at the results and then as we talked with institutions across the country. Many organizations still see themselves as just getting started in grateful patient fundraising, or they've been doing one or two things that we might categorize as grateful patient fundraising or parts of it, but haven't necessarily put that moniker on it or decided to call the program that. And when I bring Holly in later on, you'll note that at Northwestern they don't necessarily put that moniker on a lot of the things that they do. But I think this is important for all of us to know, just from an industry perspective, because I think there's a feeling in the industry that, oh, every robust fundraising organization has a grateful patient engine that works perfectly. And the reality of it is, based on what we found in this study, that both the art and science of many of the aspects of grateful patient fundraising are still evolving, even at large organizations across the country. So we asked, one question that we asked in the quantitative survey is who was involved in the program and had the option for CEO, executive staff, physicians and doctors, nurses and volunteers. And there is again a correlation between the institutions that have more individuals involved in the program and how long their program has been in place. So each of those chunks, if you sort of go down the line, takes some form of effort, some process in order to train and educate them both on the value of philanthropy to the institution, as well as the way that you'll be engaging them in working with your patients. And each of those things takes time. So again, the more mature the program, the more that we saw they had been able to integrate a number of different types of people across their institutions into the program. So when we began this process, we really wanted to say there was already a good amount of information out there in the industry, something that you could Google and figure out that there are some basic pillars that are already in place in terms of grateful patient programs. So we weren't reinventing the wheel in terms of the core aspects of a program that people often try and take on, but I did want to touch on them here and just provide some definitions and some comments. So institutional involvement and commitment, what we mean by this most specifically is that there is buy-in from both executive leadership and administration, as well as the board, into understanding that there's an importance to engaging patients as potential donors, involving physicians in that process, and that there's an impetus to invest in that, both from a human resource perspective at the foundation and from a time perspective across the system. We'll talk a little bit later about culture of philanthropy, but that plays into that institutional involvement and commitment as well. Data capture and analysis. This is very often where a lot of institutions start when they're thinking about getting into grateful patient fundraising. So being able to receive and track the census, both from an inpatient perspective and an outpatient perspective. Are you able to access data that shows you who's coming through the hospital, hopefully on a daily basis? And then as a next step in that, are you able to report in a way that shows you hopefully the giving history of people who are coming through, so you can identify if people are donors, if patients are donors, as well as a wealth screening and modeling component to that, so you can understand, okay, maybe not only are they previous donors, but is their capacity amongst the people who are coming in to our institution. We lumped in both rounding and concierge or VIP programs here because it's a way of saying, okay, how do we engage the patients while they're actually in the hospital? And how do we think about that? How do we do that? What are our policies around that? And we found in conversation with people that at institutions, culture is a really big key part of rounding, as well as concierge or VIP programs, and can dictate how far deep you can go in that. Then engagement of physicians, nurses, and other frontline clinicians. So are your people trained and trusting of philanthropy in general? So do they understand the impact, and are they willing to work with you and trust you that when they sort of open their door and let you into their world, you're going to help them, you're going to help their patients as well. And then lastly, follow-up. So do you have a documented process for reaching out to patients post-discharge, post-inpatient visit, after you've been able to look at the data and think about different ways to engage them? So let me move here to some of the discoveries from our findings that we think are a little bit outside of those normal pillars that I've just gone through and delve a little bit deeper. So the first one is that rounding on inpatients should be done selectively. Many programs, as they get into grateful patient fundraising, start at rounding. So we know people are coming, donors and prospects are coming through the hospital. How can we begin relationships with them while they're here? The volume of rounding that organizations do is highly dependent on the number of staff that you have. We got to a question in the survey very often that said, well, what's next for you, or what would you like to do that you can't do? And more the response came back, well, if we had more staff, we could see more patients. And so that's something to consider as you think about the volume of patients that you can see and the time that you can spend doing that. Our conversations indicated, one, you should be trying to visit donors as much as possible. We found that there was a lot of return for making the effort to go see donors while they were having treatment in the hospital, and that went a really long way towards stewarding them for gifts that they've made in the past, and of course beginning the qualification and cultivation process toward future gifts as well. The other part is that you should be aware, at the very least, of high net worth individuals who are coming into the hospital and visit them as possible, but really focus that visit on improving their experience. Our findings did indicate that there was a smaller return from visiting with those high net worth individuals who weren't necessarily donors already, but then again, if you were going to do it, that you should really be focused on improving the patient experience. And it wasn't there wasn't always a direct correlation between I'm going to see that person in the hospital and then be able to build a relationship with them after. So just some practical points that came out of it, as well as if this is something that you're not already doing, for you to consider. One, it's just super important to, before you just sort of show up in the hospital, train the people, obviously, who, your nurse managers, the people who are on the floor, why you're coming into the hospital, what you're going to be talking to their patients about, and just give them a good idea of what your role is going to be, which gives them the comfort to help you get in the door the right way. It's very important to develop scripts in terms of how everybody, so that you're talking in the same way as you enter the patient room, and that you all, as fundraisers, have similar objectives when you're doing this kind of work. And then lastly, and I'm going to bring this up in a couple of instances, but really be a team player. So I think sometimes in the fundraising world, there's the feeling, well, maybe we can go around marketing and legal and compliance, but it's really in your best interest as you're starting this kind of work to integrate with those departments, get them on board. And that's something that not only helps you to do things without running into roadblocks, but also begins to build the culture of philanthropy that we've talked about. So second, building trust with physicians and other clinicians, we found by far in our conversations to have the biggest impact around engaging patients in a way that leads to greater fundraising. Again and again, as we got into conversations with individuals who said, yeah, we've had some success, it was because they've been able to build good relationships with a select group of physicians, that they've been able to move patients from just being people who receive treatment in the hospital to being grateful donors. A big key for us in this is approaching relationships with physicians just like you approach relationships with prospects and donors, and not from the perspective of we want them to give, though of course we're always happy when physicians give, but really building that trusted relationship that allows them to feel comfortable making referrals to you, reviewing lists with you, and ultimately, hopefully, participating in some way in the cultivation and solicitation process of your prospects and donors. A part of that certainly is ongoing training and education, so showing them the value of philanthropy to them and their work, to the hospital or the system, and to their patients, so that they understand, okay, this is not just the foundation coming to me and trying to get money out of my patients, but that there's value comprehensively. And that kind of training can take on many forms. We've seen it done when we implement it, provide that service for clients. We've done it in group settings on an ongoing basis. We've done it one-on-one. And again, that's a cultural thing that you have to think about. What's the best way to implement that within your institution? And again, now from a practical perspective, obviously when you're thinking about working with docs, one is being very sensitive to time. Any of you know, working with your physicians, they are very time sensitive. They have short windows. So develop those relationships in short bursts, find those 15, 20, 30-minute windows. And we found that training really does work most effectively in those short time periods, even if you have to revisit it, than trying to get very large groups together. And then I would reiterate being a team player, but from a little bit of a different perspective, more of engaged champions. So who are the physicians that will play in the sandbox with you today? Get them on your team and really engage them in moving the work of training, educating, and building relationships forward. So we hear a lot about direct mail and questions around it, and for me this was a big part of what we discovered in our conversations with people, that the organizations feel it's important to work with direct mail overall, and there were some anomalies outside of this, but we found that direct mail is inefficient, especially when it's approached from a very comprehensive perspective in relationship to patients. So the idea of let's mail to everybody really wasn't bringing back a lot of return on investment. So segmentation, just in as we think about direct mail strategy in general, as you think about mailing to patients, segmentation is even more important. We found in a lot of our conversations that an honor your caregiver model produced a very good result. So making sure that a caregiver's name was integrated into the direct response piece, and that people had an opportunity, patients had an opportunity to give on behalf of those physicians and caregivers. I would add, as a part of this, beyond mail, when we think about online communications and email, I think some of the same principles apply. So segmentation, personalization, customization. One of the things that we know about direct response in general, though, is that you're going to have different audiences who respond to mail, snail mail, as opposed to email and online communications. So those messages should be slightly different because you want to think about, okay, who's that population that's going to respond to those online communications as opposed to direct mail, and tailor it accordingly. Fourth discovery for us, and we knew that this was happening in the industry to a certain extent, and it takes different forms and variations in different institutions, but having somebody within the foundation or your advancement or fundraising department who, whether they're a former physician or hospital staff member, or just somebody who is familiar and can speak articulately to the clinical process, can be very helpful from two perspectives. One is offering your donors, and in some cases prospective donors, the opportunity to interface with that person as they're approaching treatment. So what a great benefit to provide to say, if you've got somebody coming into the hospital, call me, I can connect you with this person in our department who's going to, for lack of a better term, hold your hand as you walk through this process. That can be very comforting and is a great stewardship and cultivation piece to implement. The second is, if you do have the opportunity to bring a retired or former physician into the fold, they can be a great conduit for beginning a very positive process of physician engagement, to say, here, I get this, come meet with me, let me tell you more about it. And we found in some of the trainings that we've done for physicians that they can be really essential in getting that message across to the physician community. So again, looking for the opportunity to add that person can provide significant benefit in those two ways. The last, in terms of discoveries, I've touched on the culture of philanthropy a little bit, and I think if we all raised our hands and said who's a little bit tired of hearing this phrase, we might have a number of hands go up across the country. But what do we mean when we say culture of philanthropy? And I think it's two-pronged in regards to grateful patient fundraising, and I think to healthcare in general. One is that everybody understands the impact that philanthropy can have on the institution in general. So we raise money, a building can go up, we can raise money, we can have a chair and recruit top-level folks, we can begin programs that would not have otherwise begun, we can bring in technology that wouldn't have otherwise been there. And I think as we work with our clients, we find that very often the wider audience within these institutions don't understand that there is the opportunity to have that impact. And again, I think with the advent of the Affordable Care Act and where we're going in terms of healthcare, philanthropy is going to become more and more important, so that impact is only going to grow. So that's one thing, trying to create ways in order to get that message across to everybody who works within the hospital. The second, that's more specific to grateful patient fundraising, is that they feel comfortable with when somebody comes to them and asks them, I'm grateful, I'd like to give back to the hospital, how do I do that? That the physician, the nurse, anybody who's working in the hospital knows where to direct that person to the foundation, to somebody specific who's doing fundraising. Not only do they know that, but they will do that there's a natural reaction to that question, and that there's a trust there built in that when they hand over that patient to you, so to speak, that you're going to do the right things and create a positive outcome that makes that referrer look good, makes the patient feel good, and of course hopefully has an impact on the system from a giving and philanthropy perspective. So let's take some of those discoveries and move them forward into strategies that you might be able to implement in a little more detail. I want to start off by saying we've got a basic assumption about grateful patient programs, is that you're engaging in this process as a part of an overall process in which you're engaging former patients and other individuals, of course, in a relationship building process. So it's not just implementing grateful patient fundraising techniques and then dollars flow in the door. There's a whole other world that happens as a result of engaging in these activities through sometimes lengthy cultivation, obviously solicitation, that hopefully leads to gifts. So as you're thinking about this, and depending where you are in your program's maturity, I would encourage you, in addition to thinking about, okay, where are we in our grateful patient fundraising, to also think about where are we in our relationship management or moves management program, because having both, one doesn't do well without the other. So I wanted to say that before we got into some more strategies. So the first strategy I wanted to highlight is establishing a beneficial role for fundraisers in the patient experience. And obviously this is a big, somewhat of a big and broad strategy, but the first thing to consider is how are you going to round on individuals in the hospital? So we talked about rounding on donors or individuals with a close relationship to the hospital, whether that's board members or individuals who sit on advisory councils for you, or board volunteers at the hospital. All of those people are good people to be keeping track of as they are receiving care, inpatient or outpatient, if you have the capability to do that. So one is to establish a protocol for this. How are you going to do it? Who's responsible for it? What are the different roles and responsibilities? Creating the toolbox for it. So what's the script that you're going to use? Are you going to give away something as you go in and visit people? But also, more broadly, think about, are we going to do one or the other? Are we going to just visit with donors and individuals who are close to the hospital, or are we also going to consider visiting with people who aren't yet donors, who are high net individuals that we might want to begin a relationship with? Again, this is highly reliant on both your capacity as a staff to do one or both, and then two, in terms of where your program is, if you have a need for new prospects, then you might, yes, want to consider rounding on high net individuals who are donors. If you're saturated with major donors, and God bless you if you are, then you might just want to consider rounding on donors and individuals with a close relationship to the hospital. Regardless, the strategy that we took away from the study was making sure that fundraisers do have the opportunity to play a beneficial role in the patient process, and we feel like that has benefit both for fundraising, because again, you're beginning and continuing relationships, but it also has benefit to the system when you think about satisfaction scores and just the general feeling that people walk away from the hospital with. Second, create a positive environment for physician and nurse engagement, and I would go beyond that to say other individuals, non-fundraisers who are involved in the administration or delivery of care. So the first thing we touched on just in one of the discoveries was developing a role for a clinical liaison. We saw this work most effectively within the fundraising or foundation office, but I think if you can develop a good relationship with somebody who's on the hospital or system side, that's a good strategy to interact, and I would really encourage you to look for that opportunity within your institution. The second, again, is to develop relationships in a similar way to how you develop relationships with prospects or donors. If the physicians and other clinicians are not used to seeing your face, understanding what you do, and what your ultimate objectives are, it's going to be difficult to deepen those relationships and develop that positive environment. We talked a little bit about champions, and so I think very often institutions get into this training or engagement with physicians, and it's easy to get thrown off the path when you call the first three people and they either say, no, I don't have time for that now, or I think the more common experience is they just don't respond to you at all. Don't be deterred by that. Again, obviously these are busy people, so think about the people who have been friendly to you over the years, docs who have been donors already, who have shown somewhat of an interest in the fundraising side of the house. Work with them first, develop them as champions, and then move on and grow that group that you work with. You want to work with hospital and executive leadership to promote participation. One of the hot topics right now is integrating this kind of work into the goals and metrics for physicians and other clinicians. We haven't seen that implemented comprehensively across the country, and it's certainly more prevalent in the academic setting. But I think to get your CEO and other leadership to really buy in and say this is something that everybody should be participating in can be a real game changer as you begin this work. And then lastly, and this is comprehensive but ties into some of the direct response strategy that we talked about, you want to give patients the opportunity to give back to the people that supported them. And that strategy really works two ways. It works because the patients feel good about giving back directly to somebody who helped them, but it also makes the docs feel good and encourages them to continue to participate and encourage their colleagues to do the same. Another strategy that we picked up during the course of the study was to cultivate a high quality of prospects over a high quantity of prospects, and this runs through some of the strategies and discoveries that we've already talked about. So how do we do that? So obviously, if you can, and if you haven't, I would encourage you to do so, implement the process for regularly screening the census. Make sure that you're keeping track of people who are coming through the hospital and noting those individuals who have the greater capacity to impact your institution, and that helps, okay, from a larger group down to a next smaller group. Another way is to pursue prospects within high satisfaction service lines. So obviously, I'm sure your institutions have one area that they're maybe more well known for than others. One reason to approach it from this perspective is you might have a higher volume of people coming through these service lines because your institution is more well known. But two, they might be having a more transformative or significant experience because it's a high satisfaction service line. And we found in our conversations that this was a helpful way to, a helpful strategy to pursue both in the individual outreach as well as the broad direct response outreach. Obviously, the more referrals that you can get from physicians help you, again, sort of separate the wheat from the chaff. So if you have a physician give you a name, they're giving you additional information beyond what you might have picked up in a wealth screening or based on previous history, and that's something that you want to be able to pick up on too. And then in addition to that, not only physician referrals, but recommendation from executives in the hospital, other leadership and board members as well. So the more input, qualification, almost peer review that you can be getting on your patients, on the census that's coming through, the better success that you're going to have on the back end. And in a similar way that I would encourage you not to be deterred as you're reaching out to physicians, don't be deterred when you're asking for referrals or recommendations and they're slow to come. Keep asking. The more that you stay in front of them and get it into a regular practice, the more likely they are to actually begin to provide you with some referrals and recommendations. And then lastly, I've talked a little bit about direct mail as we've gone through these. But again, segment, personalize. Let's not throw spaghetti at the wall and see what sticks. We really want to think about who our audience is, give them the opportunity to give back that ties to their experience in the hospital, and do it in a timely way as well. We had an institution that hadn't been mailing patients for a number of years, and then decided to go back and say, okay, well, let's just mail to everybody who's been a patient in the last 10 years. And let me tell you that that brought back butt gifts for them in terms of results. So really think about, we've all heard the phrase, grateful tears dry quickly. What's that timetable that's culture specific to us to make sure that we're getting in front of those people in a timely fashion. Last strategy is tying grateful patient fundraising efforts to your institution's mission and goals. And this, again, might seem a little bit obvious, and it ties into institutional commitment and buy-in as well. We talked a little bit about seeking the support of hospital executive leadership and your boards, but more than getting their involvement and commitment is creating a tie between what you're going to do in terms of grateful patient fundraising and, again, how that can have an impact on what their goals are, whether that's raising more money, whether that's starting a program, building a building. Try and show the relationship between these activities that you want to undertake and the ultimate outcome that will benefit them. Everybody wants to support things that are ultimately going to help them achieve their objectives, and this is a big part of it. Two is, and again, every institution has goals and metrics for patient satisfaction, and that's a big thing in many institutions. So you want to demonstrate how fundraisers can positively impact a patient's experience. I think anecdotally what we heard was, popping into the room, having a conversation, asking, what can I do to improve your experience, really goes a long way to improving that experience. And again, as it gets instituted throughout the institution, it can really add to a patient's positive feeling about satisfaction with their experience. And then, of course, again, provide patients an opportunity to give back. And I do feel like this is something that should be part of an institution's mission and goals as well. It's not just about, we want to provide you an opportunity to give back because we need your money, but there really are people who are grateful out there and want to find a way to give back. Very often we start working with organizations that don't have these structures set up, and I've seen potential donors get frustrated because they say, I want to do something to show you how grateful I am, and if there aren't processes in place in order to receive those gifts, integrate them with the people that provided them with care, it can often be more of a point of frustration as a point of gratefulness that the potential donors want it to be. So as I mentioned at the beginning, we didn't find a ton of variance between the different types of institutions that we looked at in terms of practice and in terms of return results. But obviously there's some things that we should highlight in terms of best practices in children's hospitals. We found more often than not that if you're going to put a moniker to the program, it's good to make it clear that it's a Grateful Family program as opposed to a Grateful Patient program, given that you're dealing with the guarantors of the patients as opposed to the patients themselves. And I know the children's hospital folks that are on the line with us are, of course, shaking their heads. Yes, we know this already. Secondly, the sort of pillars of the program that we talked about near the beginning are implemented in different ways. And again, this is around the fact that you're dealing with a different type of patient, so rounding is a little more sensitive. How you invite patients to give back is a little bit different, and how you build relationships post-treatment are obviously different as well. We found in talking with people that in doing that rounding, it's really less about looking at the census on a regular basis and more about connecting with people before they were coming into the hospital. So that role for a clinical liaison or making sure that there's an entry point for outreach and communication with your best donors before people come into the hospital was very important. And then lastly, follow-up following treatment with the families, which makes it even more important to build some of those relationships when they are there, so that when they're getting that call, they recognize your face and really understand a little bit about what you're there to do and sort of what your objectives are. So that I want to shift from bringing you some broad findings and strategies, discoveries from our study, and bring Holly Jabot in to talk with her a little bit about some of the things that they've been able to put into place at Northwestern Memorial Foundation, which supports Northwestern Memorial Hospital here in Chicago. So Holly, let me just start by saying welcome and thank you for joining us today.
Well, thank you so much for including me.
Great. So Holly was in Northwestern were one of the participants in our study, and based on that, there are some things that I wanted to ask her to share today that I think are a little bit unique to their program and highlight some of the things that we've talked about already. So Holly, when we talked and we went through the conversation in the study, you talked a little bit about how the culture at the foundation and in the hospital where you are is really one that's sort of relationship-based, and as you all have engaged in patient and physician engagement, that's really sort of the theory that you've moved from. Can you talk a little bit about that?
I'm sure. I would say that that really is a hallmark of our foundation and of our hospital, that we do try to be very relationship-based. So I am fortunate to have been here for 14 years, and our Grateful Patient program has been in existence for over 7 years, and we are one of the organizations that does not use wealth screening. So what we have really relied on as our bread and butter is really having the relationships with our donors so that our major gift fundraisers and really anyone on our staff who has a connection with our donors would be empowered to go in and visit patients. So we really concentrate on our board leadership, the donors that we know, our affiliated organizations, those members, and the referrals that those people bring in. That's where we've found a great deal of success with new prospects. In that way, we get to know people as they're here, but we're referred by people that are known and trusted to those individuals.
So that's great. It's really been a process about relying on the existing relationships that you have both with individuals who are donors already and individuals who are close to the hospital who can refer you to other individuals who may be using the hospital services.
Right, and just as you had found in your survey and we're talking about, we've built very close relationships with our clinical leaders, both the physicians who are the chairman or the chiefs of their departments or divisions, and our nursing leadership and administration. And we were really excited. A couple of years ago, our foundation was named as the Nursing Partners in Care. So we were the department chosen, in the hospital, which I think really made us all feel very good that not only have we been successful in raising money for nursing professional development, but we've also been able to get to know the nurses on the floors in a very special way, which just makes it, all the more fun to have an opportunity to know those who we all work with in a very nice way.
Yeah, and that's excellent. Well, let me just sort of, as a bridge from that relationship-based culture, I know that you all have a benefactor relations program that you offer to donors of the foundation. Can you tell us a little bit about how that program evolved and what that service involves?
Sure. Probably about 8 years ago, we did make the decision that we would extend a service to donors who had cumulative giving of $50,000 or more. We would offer them access to a 24-hour, 7-day-a-week pager service. So we have two amazing colleagues, Sally and Sean, who cover that service for us, and people have that pager number. And what we've found in the time that we have had this service, people are very respectful and really only use that pager service for emergencies, when they're on their way to the ED, or they have a parent in the emergency department, or they've just been diagnosed with something, or they have an appointment that is 4 months away and they're trying to get that expedited. So we've been able to have great success with Sally and Sean, and we have a terrific clinical affairs director who came here about 2 years ago. She had worked at the hospital and actually in a number of different nursing roles and leadership roles, but had been the head of the physician referral service. So Jean works 2 doors down from my office, and absolutely, as you said, she just gives anyone who she's able to deal with great comfort and expertise. And I could share 1,000 stories where she's been helpful, and she's able to round on the more complex cases that we work with and really provides great information and service to the people that we're here to serve.
So would you say it's that, and again, for lack of a better term, the hand-holding that people really appreciate as a part of that program?
Absolutely. And I think, just if I need you, I know you, and people will often call us, and we're able to, transfer their request to Sally or Sean or Jean, and I think that's something that has worked well for us. We know of some programs where there may be a number of people like Jean, but they maintain the relationship, so we enjoy sharing that relationship with our colleagues.
It's a great service to offer. So you talked about having been at the foundation for 14 years, and that many of the foundation staff are empowered to visit with patients. Can you talk with us a little bit about your philosophy in the foundation around rounding on patients, and sort of what are the objectives of those visits?
Well, first of all, I think that we all try to be very visible in the hospital. Our offices are not in the hospital. So, for example, our president goes through the emergency department every day just to say hello to all the staff, so he's not just there when we need a special request or are looking for someone in particular. Really, I think it is the thing that we all see as our most important thing, to have the ability to impact a patient's stay positively or to help them if something isn't going well. So, this morning I began my day circling to visit 3 patients. So, again, I think for all of us who are drawn to this profession, we really want to be helpful, and there's no way to do that more than when someone might be in need. And even if it's just breaking up the day of an extended stay, we've found people value the visits a great deal.
That's great, and so great to hear that it's something that's more than an initiative, a foundation, something that's integrated into the daily life of the hospital, even outside fundraising. Absolutely.
And, we've had a chance to do leadership rounds. A couple of years ago, our hospital did that with all of the managers and directors at even if in non-clinical roles. And I think we felt very proud that we were all so comfortable in being on the patient floors and knowing who to turn to if there ever was a need or a request that had been going unmet, unfortunately, or just to applaud people to say what a great job the team was doing, to know the right people to talk to celebrate those successes.
Right. That's great. That's great. Then I wanted to ask you just a little bit about, thoughts on developing productive relationships with physicians. I know you all have developed some structures that allow physicians to talk about their work and engage a little bit with former patients.
We have had great success with our advisory councils. So we have a number of advisory councils organized around specialty clinical areas. So for example, the Bloom Cardiovascular Institute or our transplant program. And so to have the physicians work with us to identify people who would be motivated to be involved and engaged as supporters, whether they are, introducing us to new potential donors or are hopefully substantial donors themselves. We've had a great deal of success with that. The physicians also that we work with most closely, they will at times have a patient who has a special need, or maybe they're working to get a patient transferred from another hospital. They'll call us to do some of those kinds of things because we have built an amazing network, not just within the hospital, but with our campus partners and with our certainly the hospitals that we're affiliating with. So it's great to be able to return, any favor or assistance that we can for their patients as well.
So it's the role of the foundation has become not only seen as having fundraising as your end-all be-all, but also have been able to position yourselves as key players in the everyday workings of the institution.
Right, and that's definitely been because we've all had a great commitment to that, and we've had great leadership support, but it's been a wonderful outgrowth of what we've been able to do. But we certainly are always trying to evolve and certainly don't have everything in place that we hope to. So would like to do more with outpatient visits as we've got more people coming in for outpatient procedures. And, the VIP concierge concept, we've certainly been discussing what might be possibilities here for those kinds of programs.
So even though you've got a lot of great pieces in place, you're not stopping there, still looking to grow the program.
Right, which is why we were very excited to be a part of this survey and this initiative with you all.
Great.
Holly, I did receive a question from the audience. Do you and your staff visit donors of a certain level, or all donors in the hospital?
Really all donors. So I will say I work a great deal with our planned giving program. So really anybody that I know who is a part of our Wesley Society, which is our recognition society for those donors. So it's not so much about the dollar level, it's really just about doing the right thing. So I've had people I know well say, our nanny is coming in to have a baby, will you check on her? Or my friend from school, so it's not strictly just the people that, are their best friends from the country club. It could be at any level. And again, because it's easy for us to be helpful.
Great.
Great, thank you.
So we really appreciate you joining us and sharing today. Are there any closing thoughts that you might want to share just as you think about this area of fundraising, or any advice for the folks that we have on the phone?
I just would say that it is really indescribable the impact that one can have on a patient and their recovery process or their stay here. So it certainly is one of the most rewarding and most impactful things that one can do. So if people are just getting started, I encourage them to really persevere, because it really has tremendous impact, and you're doing things for all the right reasons, but eventually the money will follow. So it's been a very, very successful program for us.
Great. That's great advice. Thanks, Holly.
I do have a couple of questions from the audience, if you guys don't mind. In terms of the process for identifying that clinical liaison, what does that process look like, or how might you articulate the first steps and how you might go about doing that?
Holly, I don't know if you have history of the folks in your office that you could share how they came to the foundation.
Well, definitely I would say that the woman who was our clinical affairs director, as I noted, she had been the director of our patient referral services. So she was somebody that we were already going to a great deal naturally when we were trying to get physician referrals or recommendations. And more importantly, the president and CEO of our healthcare system turned to her all the time. So it was really his idea to have her work with us more closely within the foundation, so that was amazing. The two colleagues that we have who man or staff, I should say, the pager service for us, they started in other roles in the foundation, but just really demonstrated such compassion and attention to detail and really had kind of a servant's heart in the way they wanted to help people. It became a natural role for these two people to fill.
And I would add to that, in the other institutions that we talked with as a part of the study that had this kind of role, very often it was somebody who had been in, so whether if it was a retiring physician but who had been involved either as a great giver or as a champion for fundraising and wanted to continue that role in some form or fashion, or like the example at Northwestern where there was somebody who was already integrated into either the admissions or referral process that was seen as somebody who could play this role. Those were some of the transitions that we saw from other institutions as well.
Great. Do you want to go over the institutional growth matrix and then go to additional questions, or?
Sure. So I won't touch on this for too long, but we wanted to put this up here and again know that it's integrated into our report. As we talked with institutions in the study, wanted to articulate beginning, growing, and advanced grateful patient programs, and just some of the check boxes that you might be able to check off as you add different pieces of this to your organization. Again, it's going to be different slightly and customized based on your size and your institution, but wanted to offer this for everybody as a piece of thinking about how you might take some of these strategies and implement them. So just some next steps, and then we can get back to a few other questions if we've got them. I would encourage everybody to begin a program of physician engagement today. So find your champions, determine a training strategy, and really start building those relationships. I think the sooner that you can do that, the better for your program. Determine a strategy for rounding. So you heard from Holly that Northwestern has a strategy that's really worked for them and has been highly successful. But think about the people coming through your doors and what's right for your institution. Gather that data that allows you to do that and develop a toolbox for getting in front of people. And then lastly, create a measurable process. So the famous adage, you can't manage what you don't measure, I think applies just as well in grateful patient fundraising. So set up processes for managing inpatient visits, building relationships with physicians, and all of the other strategies that we've talked about today.
Great. Well, we do have a couple of questions from the audience I want to make sure that we get addressed. The first one is, how are you notified when a donor is admitted as a patient? Actually, this is a threefold question. So, how are you notified when a donor is admitted as a patient? Have you ever experienced apprehension from a patient donor who may wish for their stay to be confidential? Or is there a general expectation that their stay would be made known to the relationship manager, development officer? I'm happy to repeat any parts of that question.
A very specific question. Holly, did you catch that and have any?
Yeah, I can. I think so. In terms of how we know, many times our donors let us know that they're coming in, so that's the best. But then we also have our colleagues who staff the benefactor pager service. They look at our census every day, and they're able to recognize the names of those through database management who are on our pager service. And we've got probably over 900 people that are on our service. And then the second question was related to privacy. So anything that we discuss or know is obviously very confidential. I've not ever had somebody be concerned that we would tell anybody, because we do share with people, gosh, we are just checking on you. You're a friend of the hospital and the foundation. and people want things to be confidential, and we will absolutely let people know we're not allowed to tell anybody anything. So it's just to check on them. And the third piece?
The third piece is, sorry, the question is regarding apprehension from a patient donor who wishes for their stay to be confidential.
Well, I think just the third piece, Holly, was individual's relationship manager, right. Primary manager. So how is that person notified?
And so we actually, once we find out who is in the hospital, that is only distributed to the president and CEO of our healthcare system of Northwestern Memorial Hospital, and then our foundation president. And our foundation president will let the relationship manager know if we've got somebody close to us in the hospital, and then we'll go check on them.
And I would add to that, there were a number of institutions in our survey and study who have developed reports that take the daily census, that comes through at midnight or whatever time, and goes through a process where then in the morning they have a report that shows patients who are coming through, has a well screening number attached to them, and also has giving history attached to them. If possible. I will tell you that in each of the instances where that's happened, it's a customized process depending on the patient database, the donor database, and any other databases that are integrating. And it's not something that's easy to do, but once you've got it up and running, it's something that can be very helpful for implementing these activities.
Okay. Right, and that's our process minus the wealth screening.
Right.
Great. Well, I think we're all set. We do have a couple of extra questions, but since we're a minute after the hour, I want to be sensitive and respectful to everybody's time. First off, Adam and Holly, thank you so much for your insights and for all of the great information that you've shared today. And thank you to everyone who joined us today for our webinar. We are excited that we are going to be presenting Fundraising Communications 201 on December 9th at 12 o'clock Central Time, so feel free to register at our website. We'll continue to be having these discussions, and so I think we have more to launch and more to come out, so stay tuned for that. And from all of us at Campbell & Company, we hope that you have a great Thanksgiving and a great holiday season. So thank you all very much. Have a good day.